Now, finally, let's look at two special cases or common presentations to the pharmacy. So the first would be young children under the age of 4. So allergen avoidance should obviously be discussed with these patients or their parents, and saline sprays can be effective. An oral antihistamine of choice would be cetirizine, and that's as a once daily dose. So it's licensed from age 2, however there are good safety records from age 6 months and upwards. If the patient has moderate to severe persistent symptoms, however, the first line treatment will be inhaled corticosteroids. The long-term follow-up studies suggest that there's no growth retardation if used as a once daily dose. However, just be mindful of inhaled or topical corticosteroids already being used, as this cohort often have eczema and may have asthma coexisting also. And for those patients who have resistant symptoms and have coexisting asthma, a leukotriene receptor antagonist like montelukast can be considered. And the second case will be those who are pregnant. So pregnancy rhinitis alone affects 20% of pregnancy, and pre-existing allergic rhinitis can also worsen during pregnancy. So ideally we want to avoid medications in this cohort and only use them if the benefit to the mother is greater than the risk to the fetus. Ideally, again, we want to avoid medications during the first trimester in particular, and topical administration in general should be the first line treatment option. Again, allergen avoidance and saline irrigation should obviously be considered for these patients. First line treatment will be intranasal corticosteroids with a low bioavailability, as we discussed before. So fluticasone and mometasone will be the best choices for these patients. Second line treatment will be oral antihistamines, and again second generation, so that there's less sedating and fewer cholinergic side effects.